I want you to imagine arriving in a magnificent city, right? And this city is renowned for one remarkable feature, which is complete, unrestricted freedom. Every single citizen possesses it.
Sounds quite idealistic, really.
Yeah, exactly. Every street offers a dozen different choices. Every marketplace presents an array of opportunities. And every single day, thousands of decisions are being made. Which road to follow, which people to trust, which risks to take, and crucially, which pleasures to pursue.
Right.
So at the very center of the city stands this grand building, which we'll call the Hall of Choice. And inside this hall, an intricate council carefully weighs every single decision a citizen might make.
So it's sort of governing body for daily life.
Precisely. Reason speaks up. Memory offers its advice based on the past. Emotion contributes its own lived experience. Future consequences are debated, and immediate rewards are balanced really carefully against potential risks.
And I imagine normally this system works beautifully.
It does, yeah. The citizens enjoy pleasure without becoming enslaved by it. They recover from disappointments, they learn from their mistakes, and they adapt.
Well, it sounds like a perfect neurobiological utopia. I mean, if we translate that city into the human brain, that hall of choice is the prefrontal cortex, right? That's the evolutionary masterpiece behind our forehead that provides top-down executive control. It allows us to delay gratification and actually plan for the future.
Exactly. And just like in any complex city, that executive control is incredibly fragile. So enter our detective for the day, Medlock Holmes.
Ah, I like that.
Yeah, Holmes arrives in the city and notices something unsettling. Certain visitors have begun arriving at the city gates. Some carry bottles, others offer powders, some bring pills, while others introduce, smoke, vapor, crystals, or even syringes.
And initially, they probably don't seem like a threat.
Not at all. At first, these visitors seem entirely harmless, even beneficial. They promise relief from pain. They offer confidence, energy, sleep, a temporary escape, or just pure pleasure.
Because the citizens just welcome them in.
Yeah, they do. Nothing appears unusual. But gradually, kind of imperceptibly at first, something fundamental changes in the city's architecture. The Hall of Choice no longer governs.
Right.
Its conversations become quieter. Its influence weakens. Meanwhile, another building on the other side of the square grows larger and louder with every passing day, and that is the House of Reward.
Which, of course, represents the brain's limbic system.
Hmm.
Specifically, the dopamine-rich reward pathways, like the ventral tegmental area and the nucleus accumbens. These are the primitive survival circuits, really, that evolved to reinforce life-sustaining behaviors, like eating and reproducing.
Exactly. And here, powerful messengers flood the city with intense signals of pleasure, relief, and desire. Each visit from these messengers strengthens the house's authority.
Right, the reinforcement cycle.
Yeah. Each return becomes easier. Each absence becomes harder to tolerate. Soon, the city's choices no longer feel like choices at all. The dopamine flood from these external visitors is just so overwhelming that the city actually starts dismantling its own dopamine receptors just to survive the noise.
Wow. Yeah, downregulation.
And that is the crux of it. Holmes realizes he is not investigating a failure of morality or a sudden collapse of willpower among the citizens. He is investigating a disease of decision-making.
Which brings us nicely to the core mission of our deep dive today. I mean, if you are a psychiatry trainee, a clinician seeking a sharper diagnostic lens, or simply a learner fascinated by the mechanics of the human mind, this is for you.
Absolutely. We are using Chapter 11.1 of Kaplan and Sadok's Comprehensive Textbook of Psychiatry as our structural spine today.
Yes, and we are not just summarizing it, are we? We're going to build a clinical mental model of substance use disorders, or SUDs. Our goal is to clarify the mechanisms, strengthen your clinical reasoning, and understand why, well, sometimes the greatest mystery is not why someone began using a substance, but why they can no longer simply choose to stop.
Right. And we are anchoring everything in this fundamental premise, which is that psychiatry is the study of how the brain, the mind, and experience interact. And crucially, how that intricate process can go wrong. So let's unpack this. We've established through our Medlock Holmes metaphor that the Hall of Choice, the prefrontal cortex, has been compromised by the House of Reward. To translate that loss of control into clinical language, modern psychiatry requires a radical shift in categorization.
It does.
It defines a substance use disorder not as a series of bad choices, but as a chronic biopsychosocial disease.
And every single part of that term, biopsychosocial, it carries massive clinical weight. We must view SUD through the exact same clinical lens that we use to view hypertension or type 2 diabetes.
That's the comparison that often surprises people, framing addiction alongside diabetes.
It does surprise people, yeah, but clinically, it dictates the entire treatment paradigm. I
Yeah.
mean, when a patient presents with diabetes, we understand there's a genetic vulnerability. That's the biological component.
Right.
There are behavioral and dietary patterns, which is the psychological component. And there are environmental factors, like living in a food desert or experiencing socioeconomic stress. And that's the social component.
So substance use disorders operate on that exact same triad.
Precisely. If a patient with diabetes has a spike in their blood sugar after months of stability, a clinician doesn't view it as a moral failure, do they? They view it as a recurrence of a chronic illness that requires an adjustment in the treatment plan.
Yeah, that makes perfect sense. Psychiatry demands we treat SUDs with that same objective, medical pragmatism. It is a condition characterized by expected remissions, where the symptoms are managed and the disease is quiet, and recurrences where the symptoms flare up.
To actually operationalize that medical pragmatism, clinicians need to identify the specific symptoms of this disease. The textbook breaks down the behavioral syndrome into what are often called the 3 C's of addiction.
The pillars of the condition. So what's the first C?
The first C is loss of control. This goes right back to your metaphor of the hall of choice being silenced. It is the inability to stop or cut back on the substance, even when the person desperately wants to.
So they might make a solemn vow in the morning not to drink, yet find themselves pouring a glass by evening.
Exactly. The top-down executive control has just been overridden.
Right. And the second C is craving. And this isn't just a passing thought, is it? These are strong, overwhelming, subjective urges.
Yeah, in our metaphor, this is the noise in the city getting far too loud to ignore. Biologically, cravings are often triggered by cues.
Like what?
Well, if someone has a severe alcohol use disorder, just hearing the clink of glasses or walking past their favorite pub can cause a massive dopamine spike in anticipation of the reward. And that physically manifests as an intense, sometimes literally painful craving.
Wow. And the final C?
The final C is negative consequences. Clinically, I'd argue this is perhaps the most defining feature. It's the continued, compulsive use of the substance despite accumulating verifiable harm.
So relationships are fracturing, employment is suffering, physical health is deteriorating.
Yeah, perhaps their liver enzymes are severely elevated, yet the use just continues. The physiological dependence and those cue-induced subjective urges completely override the rational understanding of the harm being caused. The survival instinct has essentially been hijacked.
Which brings up a fascinating conceptual shift that the source material really highlights. Traditionally, we think of these disorders as requiring a substance, something you ingest, smoke, or inject.
Yes. A chemical agent.
But the textbook notes a major evolution in the Diagnostic and Statistical Manual of Mental Disorders, the DSM-5-TR. Specifically, the inclusion of gambling disorder alongside drug use disorders.
Yeah, and by placing gambling disorder in the substance-related and addictive disorders section, the field made a profound philosophical and biological statement.
How so?
Well, they acknowledge that the core feature defining these conditions isn't necessarily the external chemical molecule. The core feature is the dysregulation of choice. It is the inability to control choice in a healthy and reasonable manner, and it's driven by the exact same reward circuitry.
So even without a bottle or a pill, the house of reward can still hijack the hall of choice. I mean, a slot machine doesn't inject anything into your veins, but the near miss, when 2 cherries line up and the third just barely clicks past, that triggers a neurochemical cascade in the brain that is nearly indistinguishable from a hit of cocaine.
Exactly. The underlying phenomenology, meaning the way the patient actually experiences the disorder, the loss of control, the chasing of the high, the withdrawal-like irritability when they can't engage in the behavior, and the underlying biology, they are remarkably similar.
That's incredible.
Yeah, understanding this helps clinicians see the broader architecture of addiction. It is about a pathological learning process where the brain has been trained to prioritize one specific reward above absolutely all other survival needs.
The textbook even speculates on where this logic might take the field next. It suggests that future iterations of diagnostic manuals might include things like severe eating disorders or compulsive sexual behaviors under this exact same umbrella of choice dysregulation, given the overlapping biology and social circumstances.
Right, because if the defining clinical feature is a biological and psychological inability to regulate rewarding behaviors despite negative personal consequences, then the boundaries between a chemical addiction and a behavioral addiction begin to blur significantly.
And the treatment modalities would overlap too.
Absolutely. Things like cognitive behavioral therapy to identify triggers or medications to dampen impulsive urges, they would naturally overlap as well.
I do have to push back here, though, because this is where things get philosophically tricky for a lot of people, and it's a critique you hear very often in the public sphere.
Okay, let's hear it.
If we categorize a substance use disorder alongside diabetes, and then we link it to gambling and potentially eating or sexual behaviors, aren't we risking stretching the definition of disease so wide that it absolves the citizens of our metaphorical city of all personal responsibility?
I see what you mean.
Like, if everything is a disease of choice, who is actually accountable for the damage done? It feels like it could be a clinical loophole for bad behavior.
That is the most common and, frankly, the most important pushback this biopsychosocial model faces. To navigate it clinically, we have to clearly separate two distinct concepts, which are fault and responsibility.
Okay, lay that out for me.
Well, a patient is not at fault for having a genetic predisposition to addiction. Studies show heritability rates for SUDs are between 40 and 60%.
That's high.
It is. They're also not at fault for growing up in an environment with high adverse childhood experiences, which primes the nervous system for stress. And they're certainly not at fault for the neurobiological changes that occur in their brain, the physical enlargement of the house of reward and the downregulation of their dopamine receptors.
Right, just like someone doesn't choose to have a pancreas that stops producing insulin or a genetic predisposition to high cholesterol.
Exactly. But while they are not at fault for the biology of the disease, they are entirely responsible for the management of their recovery.
Hmm.
Recognizing SUD as a disease doesn't absolve responsibility. It actually empowers it.
How does it empower it?
It shifts the clinical focus away from shame, which is biologically useless and often triggers a relapse, and moves it towards action. The clinical treatment provides the tools, the medication to stabilize the neurochemistry, and the therapies to help rebuild the prefrontal cortex's top-down control. The patient is absolutely responsible for engaging with those tools.
So we do not blame a patient for having asthma, but we do expect them to use their inhaler and avoid triggers.
Spot on. That moves us from a punitive mindset to a therapeutic one.
That's a really crucial distinction for clinical reasoning. So if we define SUD as this dysregulation of choice, how does the psychiatric field actually measure and codify it? We need to look at how the diagnostic blueprints have evolved, specifically moving from the older DSM-IV to the current DSM-5-TR, which, as I understand, was a massive paradigm shift.
Oh, massive. The shift from DSM-IV to DSM-5 is one of the most significant changes in modern psychiatric diagnosis for these conditions. Previously, we had two distinct separate diagnoses, which were substance abuse and substance dependence.
And what was the difference?
Well, abuse was generally thought of as the milder form. Doing risky things, having legal trouble, failing at work obligations.
Mm-hmm.
Dependence was viewed as the severe physical form, characterized by tolerance, where you need more of the drug to get the same effect, and withdrawal, the physical sickness when you stop.
But clinically, that distinction proved to be quite muddy and unhelpful, right? I mean, you could have a patient physically dependent on a prescribed opioid for chronic pain, experiencing tolerance and withdrawal, but without any of the compulsive, destructive behaviors of addiction.
Exactly. And conversely, you could have someone completely destroying their life with binge drinking on the weekends, but who doesn't experience physical withdrawal on a Tuesday morning.
Which is why the DSM-5 eliminated that categorical boundary entirely.
Yeah, it merged them into a single, unified continuum called substance use disorder. But it wasn't just a simple merger. They made two massive, highly intentional changes to the actual criteria.
What were they?
First, they completely removed the criterion for legal problems. And second, they added a new criterion to the craving.
Looking at that through our Medlock Holmes metaphor, it sounds like psychiatry essentially stopped measuring the damage to the city walls, the external societal clashes like arrests or lawsuits, and instead started measuring the noise inside the house of reward, subjective cravings.
That explains exactly why the field made the change. For decades, legal problems were used as a metric for severity. But the clinical field realized it is a terrible metric for a biological disease because it is inherently skewed by sociopolitical factors.
Of course. Because whether someone faces a legal consequence for drug use depends heavily on their socioeconomic status, their race, their postal code, and the local policing practices.
Absolutely. A wealthy person with a severe alcohol problem might never get a drink driving conviction because they can afford private drivers or taxis, while someone with fewer means gets arrested for the exact same behavior. Under the old rules, the person with fewer means would have an artificially inflated diagnostic severity simply because they interacted with the justice system.
So it measured society's reaction to the patient, not the patient's internal pathology.
Exactly right. By removing legal problems and adding craving, the diagnosis moves away from a socio-political framework and much closer to a true neurobiological one. Craving is a direct, measurable manifestation of the altered brain circuitry. It reflects the hypersensitization of the reward pathways.
Okay, so we have this single continuum now, with 11 possible criteria ranging from taking the substance in larger amounts than intended, to giving up important social activities, to the pharmacological aspects like tolerance and withdrawal. How do clinicians actually measure where a patient sits on that continuum?
The diagnosis is dimensional. If a patient meets 2 to 3 of those 11 criteria, it is classified as a mild disorder. If they meet 4 to 5, it is moderate, and if they meet 6 or more, it is considered severe.
Why does that specific breakdown matter in a practical setting, though? If you're a trainee listening to this, is it just an academic exercise in counting boxes?
Not at all. It dictates the entire trajectory of care. That specific cutoff, moving from mild into moderate or severe, which means hitting 4 or more criteria, is the critical threshold used globally.
Used for what?
It is the line used by clinical programs, by insurance companies, and by researchers to authorize more intensive levels of treatment. A mild designation might prompt brief interventions or outpatient counseling, but a moderate to severe designation is the clinical justification needed to open the door to intensive outpatient programs, residential treatment, or specific life-saving pharmacological interventions.
It's basically the key that unlocks the heavier clinical artillery.
Exactly.
Now, the DSM is the standard in the U.S., but the source text also mentions the ICD-11, the International Classification of Diseases published by the World Health Organization. How does the international standard differ in its philosophical approach?
The ICD-11 actually retains the separate categories. It uses harmful pattern of use and dependence.
Really? Why hasn't it merged them?
It hasn't merged them into a single continuum in the same way the DSM has, largely because, on a global public health scale, distinguishing between those who are experiencing health damage from substance use versus those who have a fully entrenched physiological and psychological dependence is still deemed useful for resource allocation in varying healthcare systems.
That makes sense from a global policy perspective.
It also categorizes substances a bit differently. For example, it explicitly separates cocaine from other stimulants like amphetamines or methamphetamines, reflecting the distinct epidemiological and pharmacological profiles of those drugs.
It's a great reminder that psychiatric diagnosis is always an evolving consensus, not an immutable law of physics. But beyond just the diagnostic criteria, how are researchers quantifying the risk and severity of use on a day-to-day basis? Like, we know the clinical criteria, but how do we measure the actual behavior that leads to those criteria?
This is where we get into quantitative metrics. In the field of alcohol research, for example, they rely heavily on the concept of heavy drinking days, or HDDs.
HDDs, right.
Yeah, the National Institute on Alcohol Abuse and Alcoholism defines this as consuming 5 or more standard drinks for men, or 4 or more for women, in a single day. It's a way to measure the sheer volume and frequency of consumption to determine the acute risk of adverse consequences, rather than just relying on the subjective psychological criteria.
And the text points out that we urgently, desperately need similar quantitative metrics for cannabis.
Oh, the cannabis measurement crisis is one of the most pressing issues in addiction research today. I mean, we have a robust, globally understood system for calculating standard drinks of alcohol. A pint of standard beer, a glass of wine, a shot of spirits, we can mathematically equate the ethanol content.
But with cannabis.
With a massive explosion of varied cannabis forms following widespread liberalization, you're practically flying blind.
Because the pharmacokinetics are entirely different depending on how you consume it, right?
Precisely. How do you equate the clinical impact of eating a 10 milligram THC gummy, where the drug is metabolized by the liver into 11-hydroxy-THC, producing a delayed but intensely psychoactive effect, with taking a hit from a high-potency vape pen, or dabbing a concentrate that is 80% GTHC, or smoking a traditional joint?
It's impossible to compare apples to apples.
Furthermore, the THC concentration in street cannabis has skyrocketed over the last few decades, moving from roughly 3% or 4% to upwards of 15% to 25%, we lack a universal metric for quantity and frequency.
And without that metric,
Without it, it is incredibly difficult to standardize clinical screening, track the dose-dependent risk of outcomes like cannabis-induced psychosis, or accurately measure treatment progress.
it's like trying to treat a diabetic patient without having any reliable way to measure their blood glucose levels or standardize their insulin doses.
Exactly.
Which brings us to the real-world impact of all this. We have the clinical blueprint, the diagnostic criteria, and the metrics. But when we apply this blueprint to the world, what is the actual scale of the crisis we are uncovering?
The scale is a public health disaster of unprecedented proportions. To truly understand it, we must trace the evolution of the opioid crisis, which has now entered its third decade and has completely reshaped the landscape of addiction medicine.
The source text lays out the chronology, and it is a chilling reminder of how medical paradigms can have devastating unintended consequences. It really started in the 1990s, didn't it?
It started with a well-intentioned but ultimately catastrophic paradigm shift in medicine, the campaign to make pain the fifth vital sign.
Right.
The Joint Commission on Accreditation of Healthcare Organizations, along with various professional societies, began pushing the narrative. Pressure, respiratory rate, and temperature. Clinicians were urged, and often mandated, to aggressively measure and treat pain.
And this was coupled with a massive pharmaceutical marketing push, claiming that new formulations of opioid analgesics like OxyContin were somehow less addictive when prescribed for chronic non-cancer pain.
Yes, which was entirely false. It's a stark example of how an empathetic clinical intention, the genuine desire to alleviate suffering, was co-opted to build a superhighway straight to the house of reward.
And that led to the first wave of the crisis.
The widespread, often indiscriminate availability of these prescription opioids led to dramatic increases in non-medical use. The brain doesn't know the difference between a legally prescribed pill and an illicit one. The opioid receptors are activated all the same.
Right. A molecule is a molecule.
Exactly.
Yeah.
This created a massive cohort of individuals with iatrogenic or medically induced opioid use disorders. But as the medical community finally realized the error and began cracking down on prescription rates and reformulating pills to deter abuse, the crisis didn't just end, it evolved.
The textbook notes a specific transition here. As pills became harder to get, the crisis pivoted to heroin, which was cheaper, highly available, and satisfied the profound physiological dependence that the pills had created.
That was the second wave. And then it evolved again into the current, infinitely more deadly third wave, which is highly potent synthetic opioids, primarily fentanyl.
And fentanyl is a completely different beast.
Fentanyl is entirely different from heroin. It is highly lipophilic, meaning it crosses the blood-brain barrier incredibly fast, delivering a massive, rapid suppression of the central nervous system.
It's that fast.
Oh, yes. It binds so tightly to the opioid receptors that it can cause chest wall rigidity, making it physically impossible to breathe, leading to rapid fatal hypoxia.
And we are battling this synthetic opioid wave alongside simultaneously rising rates of methamphetamine and cocaine use. The death toll is just staggering. The textbook notes we have lost over 500,000 lives. And then, of course, COVID-19 acted like petrol on a fire.
The pandemic disrupted absolutely everything that keeps people in recovery. The isolation cut off social support, the economic stress acted as a massive trigger, and in-person treatment services and harm reduction programs were severely curtailed.
What was the result in the numbers?
As a result, the United States recorded the most fatal 12-month period of drug-related overdoses in its history, surpassing 100,000 deaths in a single year.
There is a statistic in the text regarding those deaths that absolutely stopped me in my tracks. When we hear the word overdose, the default assumption is that it is an accidental tragedy. You know, someone took too much, unaware of the potency.
That is the assumption, yes.
But the psychiatric intersection here is much darker.
You are referring to the suicide data, and this is a critical clinical insight that cannot be ignored by any practitioner. The rates of suicide and suicide-related behaviors are climbing in tandem with substance-related suffering. The text highlights estimates suggesting that up to 30% of all overdose deaths may in fact be intentional suicides.
30%. If you pause and really think about the gravity of that number, it entirely recontextualizes the overdose statistics. It means a massive portion of these deaths aren't just accidental poisonings. They are the result of profound, untreated psychiatric despair intersecting with highly lethal means.
It's tragic. The neurobiology of severe addiction involves profound anhedonia, which is an inability to feel pleasure, especially during withdrawal. When the dopamine system is depleted, the psychological pain can be completely unbearable.
So it's not just a desire for the drug, it's a desire to escape the pain.
Precisely. This underscores why this chapter is a clarion call for mental health practitioners. Psychiatric patients are disproportionately affected by SUDs. The concept of dual diagnosis, or co-occurring disorders, is the norm, not the exception.
You can't treat one without the other.
You cannot effectively treat the underlying depression, the bipolar disorder, or the PTSD without directly addressing the substance use, and you cannot treat the substance use without addressing the underlying psychiatric vulnerability. They are inextricably linked.
Okay, let's zoom out and look at the broader epidemiology to understand the sheer volume of people navigating these waters. The text provides data from the 2020 National Survey on Drug Use and Health, the NSDUH. It's a massive survey targeting the civilian, non-institutionalized population aged 12 and older. The numbers are astronomical.
They are. In 2020, the survey found that 162.5 million Americans aged 12 and older reported using tobacco, alcohol, or illicit drugs in the past month. That metric, past month use, is what epidemiologists classify as current use.
162.5 million people. That's roughly half the country's population over the age of 12 engaging with an intoxicating or addictive substance currently.
And alcohol remains the undisputed king of substances. 138.5 million current users. But what's truly alarming for public health officials is the pattern of that use. Almost half of those people, 61.6 million, reported past month binge drinking.
We really need to define binge drinking because it's not just having a glass of wine with dinner. It's a massive acute flooding of the system.
Clinically, binge drinking is typically defined as a pattern of alcohol consumption that brings blood alcohol concentration to 0.08% or higher. For a typical adult, this corresponds to consuming 5 or more drinks for males or 4 or more drinks for females in about a 2-hour window.
That's a huge stressor on the body.
It is an immense stressor on the liver, the cardiovascular system, and the brain. And it vastly increases the risk of accidents, violence, and the rapid development of an alcohol use disorder.
What about other substances in the survey?
Well, the survey captured a rapidly emerging, previously unmeasured crisis, which is the vaping epidemic, 10.4 million users. Prior to 2020, they didn't even include specific robust questions about vaping in the survey.
It just highlights how quickly new delivery systems can emerge and take hold.
E-cigarettes, particularly those using nicotine salts, lower the pH of the vapor, making it far less harsh in the throat and allowing for massive doses of nicotine to cross the blood-brain barrier almost instantly. It captured huge swaths of the population, particularly adolescents, even as traditional combustible tobacco use was declining.
And on the illicit drug side, what did the survey find?
Cannabis is by far the most used illicit drug, with 32.8 million past-month users. That far outpaces prescription pain reliever misuse, cocaine, hallucinogens, and methamphetamines, which are all hovering much lower, around the 1.5 to 2.5 million mark for past-month use.
Okay, here is where we need to look at a vital nuance. What the text essentially outlines as the experimentation versus pathology insight. Because if you look at those numbers, tens of millions of people using illicit drugs, over 100 million using alcohol, why isn't the entire fabric of society just collapsing?
That is a crucial distinction for your clinical reasoning. The data shows that past month use of illicit drugs, the current use metric, generally represents less than 20% of those who have ever used them in their lifetime.
Wait, so of all the people who have ever experimented with an illicit drug, fewer than 1 in 5 are still using them currently?
Exactly. What this means clinically is that exposure does not equal disease. Many people experiment. They try a substance during adolescence or early adulthood, but the vast majority do not go on to develop a pathology. They do not develop the loss of control, the cravings, and the negative consequences that define a substance use disorder.
Going back to our city metaphor, lots of citizens might visit the House of Reward once or twice, perhaps out of curiosity, but they don't move their permanent residence there. The Hall of Choice retains its authority.
And this tells us something fundamental about the etiology of the disease. The disease is not just the drug itself. The pharmacological properties of the drug are important, yes, but the disease is the complex dynamic interaction between the drug and a vulnerable host.
Ah, the biopsychosocial triad again.
Exactly. It requires that biological, psychological, and social vulnerability to take root. If you lack the genetic predisposition, if you have a stable social environment, and if you don't have underlying psychiatric distress, your risk of developing a severe SUD is vastly lower, even with exposure.
However, for those where the disease does take root, the global impact is massive. The Global Burden of Disease study ranks tobacco and alcohol as the fourth and fifth leading causes of disease burden worldwide.
It's an immense burden.
So the scale of the crisis is overwhelming, the death toll is rising, and the burden is global. How do clinicians fight back? We need to transition from how the disease manifests to how it is actually managed. If you're treating this, what are the changing rules of engagement?
The very first rule of engagement is accepting the paradigm of chronic care. We mentioned this in the top of the deep dive, but it dictates the entire treatment strategy. Because SUD is a chronic disease, the clinical expectation of a permanent cure is flawed.
Right.
If a clinician expects a patient to go to a 28-day inpatient rehab facility and emerge permanently fixed, they are setting both themselves and the patient up for devastating failure.
So the goal isn't a magical permanent reset to zero.
No. Recovery involves expected remissions and recurrences. The goal of treatment is to improve the patient's quality of life, to increase their chances of remaining in recovery over time, to repair their social functioning, and to address the underlying psychiatric vulnerabilities. It is not solely to force immediate total abstinence at the expense of all else, particularly if trying to force abstinence leads to a dangerous relapse.
And a huge, indispensable part of that ongoing management is pharmacotherapy. The text is very explicit about this.
It is explicit because it is one of the most vital, life-saving messages for the medical community. Addiction treatment works.
We have medications for this.
Yes, we have highly efficacious FDA-approved medications for alcohol use disorder, like naltrexone and acamprosate. We have medications for tobacco use disorder, and most critically, we have agonist and partial agonist therapies for opioid use disorders, namely methadone and buprenorphine.
I want to focus on those opioid medications for a second and push on the logic. We defined this earlier as a biopsychosocial disease. It has three distinct components, but the text states that medications like methadone or buprenorphine are considered effective and life-saving even if prescribed entirely alone, without any concomitant psychosocial therapy. How can a purely biological intervention, a pill or a film under the tongue, be considered effective treatment if the disease is also deeply psychological and social? It feels like we are ignoring two-thirds of the problem.
It's an excellent question, and understanding the answer requires understanding the sheer, overwhelming dominance of the biological drive in a severe opioid use disorder.
Let's look at the pharmacology of buprenorphine. It is a partial agonist at the mu-opioid receptor.
Meaning what?
This means it binds very tightly to the receptor, tighter than heroin or fentanyl, but it only partially activates it.
So it turns the key in the lock, but only halfway. Precisely. Because it binds so tightly, it blocks other, more dangerous opioids from attaching. Because it only partially activates the receptor, it stops the excruciating physical withdrawal and blunts the physiological cravings. But it has a ceiling effect on respiratory depression.
Meaning it is very difficult to fatally overdose on buprenorphine alone.
Exactly. When a patient is in the grip of severe opioid withdrawal, the house of reward is sounding biological alarms so loudly that it deafens the rest of the brain. The patient is consumed by a singular survival-level drive to stop the sickness. You simply cannot reason with the hall of choice until you chemically quiet those alarms.
You can't do the psychological work of cognitive behavioral therapy if the biological house is literally on fire.
Exactly. Biological stabilization is often the absolute prerequisite for psychosocial healing. These medications are life-saving because they stabilize the brain's neurochemistry and keep the patient alive. Once the patient is biologically stable, then they have the cognitive bandwidth to engage in therapy, mend relationships, and rebuild their social environment.
So withholding the medication until they agree to therapy is backwards.
Yes. Mandating that a patient must attend therapy to receive their life-saving medication is an outdated, paternalistic barrier to care. The medication alone saves lives by preventing the fatal overdose.
That makes profound clinical sense. Stabilize the foundation first. Now, what about the frontier of therapeutics? The text mentions some emerging, quite disruptive treatments that are challenging traditional paradigms.
Yes. The most disruptive and highly anticipated evidence currently is in the realm of ketamine and Schedule I psychedelics, particularly psilocybin, which is the active compound in magic mushrooms.
Really?
We are seeing early but compelling randomized controlled trials showing efficacy for treating severe alcohol, tobacco, and even cocaine use disorders.
Which is wild to think about, using a powerful hallucinogen to treat addiction.
It is a massive paradigm shift. Ketamine works as an NMDA receptor antagonist, causing a surge in glutamate that promotes rapid neuroplasticity.
So literally helping the brain grow new synaptic connections.
Yes, and break entrenched compulsive neural loops. Psilocybin appears to act on the 5-HT2A serotonin receptors and profoundly disrupts the default mode network, which is the brain system associated with our rigid sense of self and habitual thinking.
Right.
By temporarily dissolving that network, patients often report a reset of their priorities and a sudden ability to break free from the craving cycle. However, the text rightly cautions that much more research on safety, optimal dosing, and long-term efficacy is needed before these become standard treatments.
Beyond medications and psychedelics, there's also a shift in who is actually delivering the care. The textbook highlights the formal integration of lived experience.
Yes, the integration of peer recovery coaches into clinical models. This is a move away from the traditional hierarchical medical model where the clinician is the distant, objective authority dispensing advice.
How do they differ?
Well, peer specialists use their own lived experience of navigating addiction and sustained recovery to mentor, advocate for, and support patients.
And the text notes they're explicitly supporting multiple pathways to recovery, which is a major shift.
This is key. Historically, treatment in many countries was heavily focused on strict abstinence-only models, often tied exclusively to 12-step mutual help programs like Alcoholics Anonymous.
Which work for some, but not all.
Exactly. While AA is incredibly effective for many, it does not work for everyone. Peer recovery coaches bridge the gap. They can support patients who reject traditional models or, crucially, patients who aren't yet ready to commit to complete abstinence but want to engage in harm reduction.
Harm reduction, like using clean needles or testing their drugs for fentanyl?
Yes, or simply reducing their heavy drinking days. It's about meeting the patient exactly where they are, rather than where the clinician wishes they were.
Which ties directly into the shifting landscape of public policy, which the textbook also addresses. The laws governing these substances are changing rapidly.
The policy landscape is evolving incredibly fast, sometimes faster than the science. We are seeing the widespread normalization and legalization of cannabis for both medical and recreational use across numerous jurisdictions.
Right.
And as the textbook points out, this is happening largely without the traditional, rigorous evidence base for safety and efficacy that we require for other medical therapeutics. This is despite the known harms, particularly regarding adolescent brain development and psychosis risk.
It's a massive, uncontrolled social experiment happening in real time.
It really is. On the harm reduction and treatment access front, we are also seeing major policy shifts designed to reduce barriers to life-saving care.
Such as?
For example, the removal of the X waiver in the United States. For over 2 decades, doctors had to undergo specific, burdensome training and apply for a special DEA waiver just to prescribe buprenorphine for addiction, even though they could prescribe highly addictive opioids for pain with a standard license.
That seems entirely counterproductive.
It was. That barrier was finally removed, acknowledging that treating opioid use disorder should be a standard part of medical practice. We are also seeing the implementation of safe consumption sites in places like New York City, which provide a supervised environment to prevent fatal overdoses, prioritizing keeping people alive over criminalizing their disease.
We have covered a massive amount of ground here, navigating from the microscopic neurobiology of receptors to macroscopic public health policy. Let's synthesize our key takeaways from Chapter 11.1 before we move to the learning reinforcement.
The core clinical syntheses are these. First, addiction is a chronic disease of choice dysregulation, deeply entwined with psychiatric vulnerability, genetics, and environmental stress. It is not a moral failing.
Absolutely.
Second, our diagnostic evolution, specifically moving from the DSM-IV to the DSM-5-TR, reflects a deliberate shift away from sociopolitical judgments and towards understanding the underlying neurobiology, specifically the addition of cravings and the establishment of a severity continuum.
Third, we are facing a rapidly evolving, highly lethal public health crisis, vastly complicated by the emergence of potent synthetic opioids like fentanyl, the destabilizing aftermath of COVID-19, and the deeply tragic, often overlooked intertwining of overdose deaths and suicide.
And finally, and most importantly, treatment works. But it requires a flexible chronic care approach. It involves peer support, harm reduction strategies that meet patients where they are, and critically, the utilization of life-saving pharmacotherapy, which should not be withheld pending psychosocial compliance.
Brilliant. To leave you with a final thought to mull over, it's a fascinating, almost poetic contradiction in modern medicine. We're currently living through an era where a devastating drug crisis was initially sparked by a heavily regulated, well-intentioned medical system overprescribing painkillers. Yet the newest frontiers of treating that very addiction might rely on legalizing psychedelics, essentially using one profoundly altered state to reset the dysregulation caused by another. The boundaries of what is a poison and what is a cure have never been more blurred.
A profound paradox that clinicians will be navigating for decades to come.
All right, let's move to our learning reinforcement section. We want to test your clinical reasoning based on what we've just discussed. I will present a clinical scenario or question based on the text. I'll pause for a moment so you can think of the answer, and then we will talk through the correct reasoning. You can also refer back to the chapter as we do this.
Sounds good.
Question 1. Think back to the diagnostic evolution we discussed. The DSM-5-TR made a major change from the older DSM-IV regarding the specific criteria used to diagnose a substance use disorder. What was the most significant swap they made, and why? Take a second to think about that. Okay, if you thought to yourself they removed legal problems and added craving, you are absolutely right.
And the clinical reasoning behind that, as we discussed, is that legal problems are heavily confounded by sociopolitical variables like race, class, and location. It is not an objective measure of biology. Craving, however, directly reflects the neuroadaptation of the brain's reward circuitry. It roots the diagnosis firmly in medical science rather than the justice system.
Question 2. Imagine you are working in a clinical triage program. You are determining eligibility for an intensive level of substance use treatment services, like a residential program. You evaluate a patient using the DSM-5-TR criteria. How many criteria must the patient meet to cross the threshold into a moderate or severe diagnosis, which is typically the cutoff used by insurers to authorize these intensive services? Have a think. The magic number is 4.
Yes, meeting 2 to 3 criteria is mild, but hitting 4 or more pushes the diagnosis into the moderate or severe category. This is the crucial standard cutoff that justifies heavier clinical intervention and opens up resources for the patient.
Question 3. The inclusion of gambling disorder in the substance-related and addictive disorders section of the DSM-5-TR raised some eyebrows. Why is this considered an appropriate, scientifically sound move for the field of psychiatry? Ponder that for a moment. It all comes down to the concept of choice dysregulation.
It's exactly. Gambling disorder, even without a chemical substance entering the bloodstream, shares the core phenomenological and biological features of addiction. The dopamine pathways respond to the anticipation of the gamble, just as they do to a chemical, leading to an inability to stop the behavior despite accumulating negative personal and financial consequences.
Question 4. Let's test your epidemiological knowledge. Based on the 2020 National Survey on Drug Use and Health data, what is the general statistical relationship between a person's lifetime experimentation with an illicit drug and their likelihood of being a past month current user? Think about the percentages we discussed. The key insight here is the 20% rule.
Past month use generally represents less than 20% of those who have ever used an illicit drug in their lifetime. This highlights the vital difference between mere exposure to a substance and the development of a pathology. The disease requires a vulnerable biopsychosocial host, not just the presence of the drug.
Question 5. You have a patient with a severe opioid use disorder. You prescribe buprenorphine, a partial agonist. However, the patient flatly refuses to participate in any specific psychosocial or behavioral treatments. According to current clinical guidelines, is the medication still considered an effective treatment? Have a quick think about the pharmacology. The answer is a resounding yes.
While comprehensive, multimodal treatment is always the ideal. The biological stabilization provided by buprenorphine is profoundly effective at preventing fatal overdoses and managing severe withdrawals. It is a life-saving intervention on its own and should not be withheld simply because a patient is not ready or willing to engage in talk therapy.
Question 6, our final question. In the context of modern recovery models, how do peer recovery coaches fundamentally differ from traditional clinical staff? Think about their background and approach. It's about lived experience and flexibility.
Peer recovery coaches step outside traditional rigid medical hierarchies. They utilize their own lived experience of addiction and recovery to mentor patients. Crucially, they often support multiple pathways to recovery, offering flexible, harm reduction support that doesn't necessarily mandate immediate total abstinence, meeting the patient exactly where they are in their journey.
Here are the details of this episode.
Substance use disorders. Introduction. Byline. Sometimes the greatest mystery is not why someone began using a substance, but why they can no longer choose to stop.